are ready to get started. Sorry about that, everyone. So for those of you who are still with us, I believe most of you were here when I presented on trauma and trauma-informed care, but today is specific training for the screening that we're implementing within the PEDS specialty clinic starting on April 16th. So on April 16th, we will start screening all 4, 11, and 16-year-olds who are coming in for KBHs to assess for any trauma and any symptomatology related to that trauma. So the next 40 minutes, Vanessa Loaf will be with us presenting on that topic and specifically what our roles as healthcare providers will look like. So Vanessa's here from Wichita State University and she's the community educator on trauma-informed care. And so Carly has passed out to all of you the protocol that is in place as well as both screening forms. So there's a screening form for children as well as adolescents. So take it away, Vanessa.
Hi guys, sorry about the technical issues. How many of you have seen me before? Oh, good. So that means that you probably came to the training that I did about adverse childhood experiences, right? This is not that. So just so you know, I'm not going to make you sit through that again. Although for those of you who weren't there, we are going to do a quick discussion of why we're doing this screening so that everybody is on the same page. But then as Dr. Nutting said, we're going to particularly go through the protocol that you're implementing. So here goes. So what if I were to say to you that we, meaning the CDC and many other researchers across the country, have discovered a threat that dramatically increases the risk of 7 out of 10 of the leading causes of death in the US, that affects brain development, the immune system, hormonal systems, and even the way DNA is read and expressed. Triples the lifetime risk of heart disease and lung cancer and can potentially reduce life expectancy by up to 20 years. What would you say if I told you there is something like that out there that does this? What's your response?
We gotta do something about it.
We gotta do something about this, right? Well, that thing is adverse childhood experiences, believe it or not. So if you're not familiar with the ACEs study, the original landmark study was done back in the late 1990s. And it was a partnership between Kaiser Permanente and the CDC in an obesity clinic that in middle class San Diego, California. And through that, they discovered there are 10 types of adverse childhood experiences that can be directly linked to the risk of those potential life-threatening diseases. Those 10 include the ones that you see here, which are physical, emotional, and sexual abuse, physical and emotional neglect, living with a family member with mental illness, having an incarcerated relative in the household or incarcerated, and witnessing mother being treated violently, divorce, and having a household member using substances. So those were the original 10 that were part of the study. Study after study after study since then has replicated these results with some pretty amazing data. But the most recent data that we have is here. For those individuals who have what we call an ACE score, so they have 4 or more of those 10 that I just showed you, their risk of heart disease doubles, the risk of cancer and stroke doubles. Nobody's really shocked about the suicide one, right? People think you've had a rough childhood, your risk of suicide is probably pretty high, although 30 times is really darn high. Any of those surprise you? Alzheimer's. Any guesses why Alzheimer's might be one of the ones that it increases risk? Or has an increased risk?
Maybe like chronic inflammation leads to some of the increased, whatever it is, tau proteins or whatever.
Yeah. So what we know about chronic adverse childhood experiences is that it sets off a chain reaction in that neuroendocrine immune system. And over time, being washed with cortisol, so think about that. How do people typically react to a bolus dose of a steroid or something, a corticosteroid? How do their systems usually react? They blow up, maybe, right? Not literally, but they have weight gain. They maybe have some behavior changes, right?
Mood changes.
They have mood changes, lots of stuff going, their immune systems get suppressed, right? All of those kinds of things happening. Now think about that every single day of somebody's life. Those are the kinds of changes that we're going to see and the damage that is done to that neuroendocrine and immune system, leading to potential for risk with Alzheimer's and ischemic heart disease and some of those others. The other thing that we know now is that it can literally change how DNA is read and expressed, which has implications for our pregnant moms, right? Because if they're under stress during pregnancy, we all know it's bad for a baby to be washed in toxic chemicals while they're marinating in there before they come out, right? I'm sorry to my pregnant mom that's in the audience, but we know that that's a bad thing. What we also know is that the increases we sometimes see in ADHD and some of those other issues that we call ADHD really might be a nervous system damage rather than attention deficit disorder. We could get really super deep in this, but I'm not a doctor. I don't play one on TV, so we'll let your faculty talk about that more. There's also a really super great book that just came out a couple of months ago called The Deepest Well by a pediatrician called Nadine Burke-Harris. Have any of you heard of Nadine? Dr. Nadine Burke-Harris is the medical director of the Bayview Hunters Clinic in San Francisco, which is a very low income area of San Francisco. And through the work that she's done in combination with the years of study happening with the CDC, they have started to develop protocols for screening kids for ACEs because they have seen in their own clinics the huge amounts of damage that this is doing. Her book starts with a story about a little guy who comes into her clinic that is in the 50th percentile for growth for a 4-year-old, except that he's 7. And what they determined was that the 7-year-old had experienced sexual abuse at age 4 and stopped growing after that incident. So some of these failure to thrive kids that you may see coming into your clinics, there may be more to that story that you need to look into. And that's why we're having this discussion. What we know now is that adverse childhood experiences leads to those disruptions of the neuroendocrine and immune functions. It can lead to social, emotional, cognitive impairment, and often leads to adoption of health risk behaviors. So things like smoking, overeating, not exercising, using substances, all of those things, which of course are going to potentially increase the risk for disease and disability and social problems. But what they've also found are for those folks that have had these experiences and have had no symptomology and have not adopted those health risk behaviors, it only attenuates 50% of the risk. That's kind of a big deal. So even if I eat right, exercise right, but I have an ACE score of 8 or more, I'm still at higher risk than somebody who has not had those experiences for all of these different potential life-threatening diseases. What we also know is that this is a dose-dependent response. So just like other medications, when you take too much of it and it has a negative impact, that's true for ACEs as well. So the goal is to identify these adverse childhood experiences as early as possible so that we can reduce the risk of accumulation over time. If we don't, we might see things like growth delay, cognitive delay, sleep disruptions. As the kiddo gets older, we see uncontrolled asthma, increased susceptibility to infection, learning difficulties, behavioral problems, and some of those things we expect to see for somebody that's had a difficult childhood. But then we start looking at obesity, teen pregnancy, and smoking as they get earlier, and that's where you all can make a difference and make an effort to try and identify these things earlier and reverse some of the issues that could lie ahead for these kiddos. If we don't do something, as I mentioned earlier, the life expectancy, what they found in the ACEs science, it can be reduced by up to 20 years. There's decreased quality of life. There's increased healthcare costs from the chronic conditions that result. And we do see increased rates of smoking, alcoholism, and drug use. Dr. Denise Dowd, and have any of you ever worked with Dr. Dowd? She's from Children's Mercy, actually, in Kansas City. And she won the American Academy of Pediatrics Gold Foundation Humanism Medicine Award in 2015. But she and others across the country are calling ACEs not only a national public health crisis, but a global public health crisis, and probably the leading public health issue of our time. So in response to that, the AAP in 2012 started calling for pediatricians in particular to start screening for adverse childhood experiences. I'm not going to read the slide to you because you all are in med school and you know how to read. But the AAP has been saying for 5 years now that the best way to mitigate these negative effects is from some intervention from their pediatricians. The World Health Organization has been calling for screening since 2009, but for many people, and I'm finding more and more in the medical field, they've never heard of this science before. How many of you, before we did the training here or before today, has heard of the adverse? Good, some of you have, wonderful. It's starting to get traction. If anybody saw 60 Minutes, a couple weeks ago, Oprah did a whole story with Dr. Bruce Perry on those impacts. It's starting to get wider known, but it's taken almost 30 years to get there. The good news is, in the US anyway, we're pretty good at addressing public health issues, right? Look at the advancements that we've made in smoking. I mean, we haven't eliminated, but things are a lot better than they were 30, even 50 years ago. The advancements that we've made in HIV detection and treatment. People are living a lot longer. Hep C is another one where we've made progress. And there are 4 ways that we have successfully tackled some of those public health issues. And the first one is that raising awareness in public education. If you as physicians have never heard of this, it's probably pretty likely your patients have not, and have not made the connection between adverse childhood experiences, toxic stress, and their long-term health. We always tell adults that stress is not good for you. We talk about it's not good for your heart and all of that, but we never have this conversation as it relates to babies. And the timing is incredible. So if you think about hypothyroidism in an adult, we can treat that, we can manage it. What happens to an infant whose thyroid isn't working properly?
They don't grow.
They don't grow.
They can die.
They could die, right? So timing is everything. The timing of these adverse experiences and toxic stress is everything to those developing children. So routine screening is another piece of that. It's part of our vernacular to ask people if they smoke when they come in as a new patient, right? Do you smoke? Do you drink? Some of those other kinds of things is just part of our routine. We would like to see routine screening for adverse childhood experiences so that we can intervene early, and once it's done, but you can prevent more from happening. and then implement best practices and continue to conduct the research that's necessary to discover new strategies for potential prevention and treatment. The AAP did a study with pediatric primary care in particular, and 300 pediatricians said it's part of their job to screen families for the risk factors every day, and that the advice that they give, people listen to doctors for the most part. They may not do what you want them to do, but they listen to doctors, right? And so you are one place that can have more impact than any other, especially on kids under 5, because not all of those kids go to childcare or school, and they may be seeing their doctor when they're not seeing anybody else. So let's get to it. Let's talk about the protocol. You all have a copy of it in front of you, and as Dr. Nutting said, we're going to start implementing this in April. You should have received, I think in your email, a copy of the actual screening forms if you didn't get it today. Is that right, Dr. Nutting?
They have the email, but they also have the screening forms.
Okay. So you'll see for our 4-year-olds and 11-year-olds will receive this screening form when they come in for their well child checkups. And this particular form was created by the Center for Youth Wellness under the direction of Dr. Burke Harris. And you'll see that this is not a checklist. Parents or caregivers will be given this when they come in as part of their intake paperwork. And whoever gives them that paperwork is going to explain to them what this form is and how to fill it out. And what we want people to do, if they can read, let me just point out that you have to be able to read to do this. Mark down which ones, not which, but how many of these they're affected by. So all we're asking for is a number in the box. The first 10 are the original ACE questions, but what we know is that kids experience lots of other kinds of stressors, and so there are 7 additional questions for the younger kids, and then they mark a separate number for that particular score. So all they are reporting is the score. It is possible for someone to have an ACE score of 5 or more and not experience abuse or neglect. So I want to make that really clear, that don't make assumptions based on the score, which ones they've marked. They may self-report to you which it is, and you're going to go through your normal protocols for reporting abuse and neglect. But this form alone does not trigger that process. Now, if you get an ACE score of 10, then you know you have some additional questions to ask, because there probably is some abuse and neglect somewhere in the child's history. But we are not asking for specifics on this form. We're collecting the numbers. For the teenagers, there's actually 9 additional questions, because there's some questions about the child's own experience with incarceration or being physically abused by a romantic partner, some of those kinds of things. Again, this is parent report. This is also an optional form. So if parents don't feel comfortable filling it out, that's okay. For now, this is an optional form. We are giving it to them, asking them for the information, and then collecting the number. But if they refuse, you can give some additional explanation of why we're doing this, and they may decide they want to fill it out, but it isn't mandatory. For the teens, for now, we're just going to have the parent report and have that completed by for our 16-year-olds that come in for well child checkup. Just for your information, there is also a self-report form. We're just not implementing that at this time. But we know that sometimes kids will report what parents don't, right? Or the other way around. Parents will tell you what's going on and the kid won't. But right now we're going with parent report.
So are these questions, like, are they supposed to be asking, like, their children some of these? Because some of them, it seems like, to me, like, the parents may not necessarily know.
And that's true. They can, if they want to ask their kids, have you had this experience? And it may be a way to start a dialogue that hadn't been started before. Yeah. But you will not ask those questions directly. So thank you for clarifying that. So the way this is going to work is the appropriate form goes to the caregiver by the front desk staff, and they're all being trained separately. So you all can rest assured that the administrative staff and the nursing staff are all being trained also in this form. The caregiver completes it, gives it to the person that is going to room them. Then that person passes that on to the resident physician. Residents, your job then is to check the results before you meet with the patient and know that they're going to be reported as two separate numbers, but what you care about is the aggregate number. They're being reported separately for data collection purposes, but what matters is the combined scores. So if you have 3 on the top and 2 on the bottom, it's a combined score of 5. This is how you would typically respond. So if you take a look and you've got an ACE-Q score of 0 to 3 total, and with some additional questioning from you, questions that you're probably already asking, how's the kid feeling lately? Are they having trouble at school? Are you seeing headaches or tummy aches? All those things you normally ask. And the doctor says, the parent says everything is fine, then you can do some anticipatory guidance. And just say, the reason we're asking this is because we have new science that shows that stress is hard on a kid's body. And it looks like right now, things are going well. But if that changes, let us know, because we know the earlier that we intervene, the better the outcomes are. And that's really all your conversation has to be. It can be more. If you suspect that mom is saying everything is fine, and you can tell by looking at the kid and mom that everything's not fine, still do your job as doctors and ask the questions that you should ask. But you don't have to ask specifics if it looks like things truly are going well. On the other hand, if they have a score of 1 to 3 with symptomology, or they have an ACE score of 4 or more, then you want to have a different conversation with them. Have the conversation of how are you doing, how are things going, what is going on at school, and then if it seems appropriate, offer support. Offer a warm handoff to Dr. Netting and her team if it's a day that they're available. And if not, talk with them about when you might be able to connect them with some additional resources. It might be something as simple as a United Way referral, the referral sheet for United Way services. It may be more than that, but you can make that assessment as a doctor. We want you to be sure and talk to them about why you're making that referral. It may be that they've had some issues that they've already been to therapy and that kind of thing, and that's okay. If it's 4 or more and they're not showing any symptoms, you can just let them know this is why we're asking and we're going to keep checking. Questions about that piece of it? Dr. Netting, do you have anything you want to add?
Yeah, just to follow that up really quickly, there is a specific referral sheet that I made up that will be in the PEDS precepting room. And this referral sheet is divided into a couple different sections. I have a couple that I can send around, but one is just community resources for developmental purposes. That includes rainbows and providers like that. Another section includes support services such as Big Brothers, Big Sisters. And then the third section includes therapists. So really kind of depending upon what children are presenting with, we'll determine that for the referral. And so Monday through Wednesday, myself or Carly are available for consultations. And then, so anytime there's a positive screen, you can certainly have us consult, and then we can determine the best referral or impulsive patient within the clinic. And then Thursdays and Fridays, you can certainly send me a patient message and or refer them to a provider that would be appropriate on that referral sheet.
Great, thank you, Dr. Netting. Any questions for her about that?
Are those going to be available in the family medicine side?
That's what I was gonna ask.
So, because I have patients that I know are positive without doing the questionnaire.
Sure. Yeah, I can certainly, so right now we're piloting this questionnaire within the police clinic, and ideally in the next year or so, we'll be transitioning it to family med side as well. But I can certainly put the referral sheet in family med side, I'll put it next to the referral sheet we have for therapists and psychiatrists.
The other question I had to do more with, I could see this overwhelming the system. Like you know how you aren't supposed to screen for depression unless you have the resources in place to take care of everything? I could see this literally just overwhelming the whole system, and then we're stuck with these questionnaires that are positive and then not being able to do anything with them.
So, and that's partly why we're piloting this. So right now, with ages 4, 11, 15, we're only screening 184 patients a year. And so that's fairly doable, especially when people are expanding ideally into those providers. So we think that will be able to.
You're saying the Pete's Clinic only has 184 patients that are 4, 11, or 16?
Getting KVHs each year. So,
Okay.
So the only people we're screening are KVHs.
yes, at this point.
For their well-child checks.
So would you encourage or discourage us from going through and talking about, so you got a score of 3, which of these were positive, and tell me more about that.
I would discourage it unless
Okay.
you suspect, particularly with abuse. If you suspect something's going on, do your job and
Okay.
ask. Please feel free to do that.
Why would you discourage it?
Because it puts you in a position of having to report.
Okay.
And if you really think that that's the issue, then please, by all means, do what you need to do and report. We want you to report. But this way, families are more likely to share if they know it's just a number and talking about how it impacts their health. But I also want to, I'm a former child welfare social worker, so I'm going to be the first one to say if you suspect there's abuse, please do what you need to do to address that. But as far as bringing it up here, if they have a score of 3, it could be mom uses drugs, dad's in jail, and they're divorced. None of that is reportable necessarily, depending on what the issue is and how severe. So it's more about just having that conversation of, wow, look at all the stuff that's stressing your family and what we can do to prevent from impacting your kid's health. It's also a great time to bring up self-care for the parent and say, wow, it sounds like you've got a lot going on. And if you think you need additional help, we're happy to get that for you. But this is why we're asking, is because we want to make sure this stress isn't doing long-term damage to your kid. Yes, ma'am.
I'm wondering why it's being emphasized that it's voluntary, because when it comes to health literacy, what I've experienced is the only word they understand is voluntary. And especially when there's this much reading and you have to do math without circling things and then like add it up and not want to know. I'm a little concerned that patients are, if I don't have to do this, I'm definitely not doing this.
So it's all in how you present it. And you don't necessarily have to say it's voluntary. You can say, here's the form, please fill it out. And if they say, I don't want to, you say, okay.
But the front desk script says, it's very clear, this is voluntary. So that's why the time
That's
it
a
gets
good
to us,
concern.
by the time it gets to us, they're already gonna have heard 3 people, maybe 2, say it's that's my concern with vaccines and stuff too. Like by the time that we get in the room, sometimes they've had kind of counter education. So I just think that would be important for the front desk script, like maybe not to emphasize that so much, and then they could opt out. And then if they say like, well, I don't want to do this, they say, okay, that's totally fine. But to give them that option off the bat seems a little bit like we're not gonna
That's good feedback.
get a lot.
I
Yeah.
think at this time, we'll leave the verbiage as voluntary because that's what the IRB approved. So.
That's good feedback though, and we need to pay attention to that. If nobody's filling it out, then we need to take some assessment during the pilot project and say, is this maybe why they're not filling it out?
Because it is a study, right?
At this point,
Because you
it's
said
not
it
a
would-
study, but we want to do retroactive study at some point, yes. It's-
That's why you got IRB approval.
Yeah. Yes, ma'am.
I'm wondering if we need to have these ages come in like 5 minutes early, has that been discussed?
I'm getting ready to get to that. So thank you for asking that question. That's great. Thank you for that. So back to symptomology. All of these things, and I know you all probably know this, but thinking about taken an ACE score of 2, but we're seeing developmental regression, we're seeing failure to thrive, we're seeing an increase in enuresis and encopresis, trying to help you connect some of those dots, that if there are unexplained symptoms, like, you know, we have chronic tummy aches and headaches that are unexplained and we can't find them anywhere else, what's their ACE score? And maybe that this is a toxic stress response, not just a medical issue that we can't find. That there may be another explanation for what's going on. In the pediatric setting, parents usually find that this kind of information of, hey, you know, this can impact your kiddo's brain development and how well they do and learn in school and how they behave. A lot of times they don't know this information, and particularly parents of kids under 5. And what they're finding in these 2 studies that are quoted here, that parents are receptive to having those conversations. Most parents want to do the right thing for their kids. They may not take care of themselves so well, but they want to do the right things for their kids. Their ability is another issue, but they want to. And having that information will help them do that. So, to answer your question about the feasibility and time, there was a study done with family practice physicians back in 2015. This was a screening of adults, and I want to make that really clear. But the patients that they screened, they did all of their adult patients in this particular study. They didn't express distress with answering the ACE questions, because that's the other thing. People will say, I don't want to open a can I can't close, right? And what we find is that we don't see that happen very often. And if they're acutely having an episode, you need to intervene anyway. And so, but what we have found is patients don't express distress with answering the questions. The clinicians that were in the study found that it actually gave them a more complete medical history. And so they were able to make some decisions about their care a little better. And 3% of the people with any kind of ACE risk of 1 or higher, only 3% required 10 or 15 minutes more in their visit, but 91% it added less than 5 minutes to the visit to have the conversation. So one of the things that I realize that's the difference between talking to adults and talking to parents about their kids, that anytime you ask parents to talk about their kids, a lot of times they're going to go on for a while anyway, right? Everybody wants to tell their story and how great their kids are or are not. But what we're finding is the screening itself doesn't necessarily add that much time to the visit, just a couple of minutes to have the conversation, while it's still giving you a better picture of what's going on. So, we have a couple minutes to do practice. What do you think? I would like to give you time to ask more questions though, because I kind of flew through that. It's not super hard. Please ask questions.
I just wanted to note one thing too. So at this point, when you are charting for these patients, in your note, you'll type in their total ACEs score. In the next couple of months, we will have a place within the chart to document that. So Nancy Swank is working on getting that built, but it's not built at this time. I'll let you all know when that is built. So right now, just put it in with your note.
And then there's a specific basket that these screens are going into for that process.
And so you can provide the forms to your nursing staff at the end of the encounter, and they'll collect them because they're going into a basket. It